Hey, VetFolio Voice peeps, welcome back. This episode is sponsored by Hills and features Dr. Shadi Ireifej here to talk to us about common emergency presentations and nutritional considerations when managing these cases. We cover not only the importance of choosing the correct food when managing these patients, but also optimal timing for introducing enteral feeding and methods for enteral nutrition in patients who maybe don't want to eat or who have a condition where per-os feeding is contraindicated. We talk about nasogastric tubes, esophageal tubes, J tubes. There's even a little nugget in there about total parenteral nutrition or TPN. As you can imagine, there's a lot to cover here, so let me go ahead and introduce Dr. Ireifej and let's talk nutritional considerations in common emergency cases. Dr. Shadi Ireifej graduated from the State University of New York at Binghamton, where he received his Bachelor of Science degree in biology in 2001. He then attended Cornell University, where he received his Doctorate of Veterinary Medicine degree in 2006. After completing his studies at Cornell, Dr. Ireifej completed a one-year small animal medicine and surgery rotating internship at Angel Animal Medical Center in Boston, Massachusetts, followed by 2 small animal surgical internships at Long Island Veterinary Specialists. Dr. Ireifej became a diplomate of the American College of Veterinary Surgeons in 2012. After operating for almost 10 years at Long Island Veterinary Specialists, Dr. Ireifej elected for warmer weather and transplanted to Las Vegas, Nevada in 2016. In Las Vegas, Dr. Ireifej became a staff surgeon at Las Vegas Veterinary Specialty Center. In 2017, he began flying across the United States, performing surgeries at a number of emergency and specialty hospitals in need of surgical assistance. This was followed by a chief of surgery position at United Veterinary Specialty and Emergency in Silicon Valley, California. Managing their 3 locations, Dr. Ireifej and his team successfully cared for dogs and cats in the Campbell, Mountain View, and San Jose areas. In 2018, Dr. Ireifej joined True Care for Pets in the Los Angeles, California area as Chief of Specialty, where he was instrumental in morphing the after-hours and weekend emergency hospital to a successful 24/7 emergency and multi-specialty veterinary hospital. In 2020, Dr. Ireifej changed gears, finding a novel and state-of-the-art means of reaching concerned pet owners through the platform VetTriage, where he currently serves as Chief Medical Officer. Dr. Ireifej has been published in scientific and medical journals and enjoys lecturing to a variety of audiences. He's known for being a positive force and energetic force both professionally and personally. He has since been featured on numerous media outlets, including television, podcasts, radio, articles, and conferences. Dr. Ireifej is frequently sought after for giving in-person and virtual talks on the current state of veterinary medicine, the current and future paths of veterinary telehealth, and how to empower up-and-coming veterinary professionals so that they have the tools necessary for a successful and rewarding career. All right, let's go ahead and jump into our episode. Well, for this episode, I'm joined by Dr. Shadi Ireifej, and we're going to talk about some common emergency cases and some GI considerations and ways that nutritional management might play a role in these cases. So, Dr. Ireifej, thank you so much for joining me.
Thank you for having me. It's a great pleasure to be here.
Yes, happy to have you and really interested to hear your take on these cases. And kind of starting off, I understand that you have kind of a certain way that you think about GI symptoms and a way that you teach that to veterinarians that you're maybe mentoring. So can you walk us through that a little bit?
Yeah, this is of paramount importance, especially to new graduates, interns, even residents, because you leave vet school with what I call a soup bowl full of different differential diagnoses, and it's confusing. And gastrointestinal is the number 1 most common condition you see, whether you're talking about general practice or emergency. It's such a common issue, or virtually, like on VetTriage. So it's important to try and categorize the gastrointestinal tract in your mind as a doctor, especially as a new doctor, as opposed to having all these different differentials, foreign body, cancer, GDV. So you try to think of GI as primary versus secondary. Primary, anatomically speaking, being the gastrointestinal tract itself, stomach, small intestines. Secondary being anything outside, extra GI, so brain, urinary bladder, things like that. And if you start off with that mentality, then once you can pinpoint which part of the body system you're talking about, differentials come from that anatomic location.
And I think when we were initially, kind of talking about this episode and everything, you compared it to localizing the lesion with like a neuro case, and that really resonated with me. I went, yeah, absolutely. I'm going to put it all together to figure out where the problem is, and it sounds really similar to that.
Absolutely. We do that routinely, or we should be doing that routinely with the nervous system. Is it central nervous system or peripheral nervous system? And if it's central nervous system, are we talking about brain, C1, C5, C6, T2? Onwards. And then based on the location of the lesion, based on your physical examination and the patient's history, the signalment, the clinical signs, we then can say, okay, this is localized to C1, C5. What's most common in Dalmatian? Well, we've got lateralizing herniated disc is probably number one, more so than something like fibrocartilaginous metabolic myelopathy, FCEM, right? And so GI is the same thing. If you can pinpoint and say, okay, based on my diagnostics, my physical exam history, I think this is the stomach. Well, then what are your stomach differentials? And everything from Helicobacter to GDV to gastritis, foreign body, et cetera. Then it's a much easier and more structured way to think about these cases.
And, of course, in veterinary medicine in general, we want to be targeted in our diagnostics. And I think probably narrowing down the location of the lesion will help us with that. What kind of diagnostic tests should we be thinking about? Maybe, in context of before and after we've localized where the problem is coming from. And how would you say that those most commonly are guiding us through our diagnosis and treatment plan?
Especially this day and age where access and spectrum of care is a major problem, not just financial limitations for pet owners, but also geographic, right? And to some degree, cultural. And so what you're trying to do as a veterinarian is offer the best, right? The standard of care for your client, offer them all the options, let them decide based on their own ethics, their own culture, their own finances, their own pet's quality of life, et cetera. What is the best decision for them? You give them plans A through D or whatever, go through pros and cons, costs of each, and then they have to decide from there. So if you can fine tune your testing to a specific anatomical location, that'll help you be able to be conscientious of the fact that not everybody can afford all the tests all the time, and you can sort of prioritize. If I had to choose between abdominal radiography versus abdominal ultrasonography, well, I have to choose between the two of them. They're very different, and synergistically, they're great. But if you only can do one, then what's the most likely going to get the most information for that particular case?
And, certainly findings on CBC Chem and things like that, helping us to localize primary GI versus secondary and coming from outside of the GI tract.
Correct. We a lot of times try to preemptively think that a pet owner won't be able to afford or they don't want to do everything because of our own biases or because we are characterizing that pet owner. And so we tend to say, well, let me just offer them this instead, because they probably won't do everything else. And I'm wholeheartedly against that. I think you ought to offer the best and then work your way down from there if they can't afford the best or they don't want to do the best. So a full biochemistry panel, so a chemistry and a complete blood count, so a CBC is minimum. If you want to be really thorough about it, you want a chem CBC plus probably urinalysis, probably urine culture, and then thyroid panel, again, depending on the case. But that's sort of your minimum database, especially for a middle-aged to older pet, dogs in this case. And then from there, some sort of abdominal imaging. Most people start off with abdominal radiographs, which we can talk about in detail about how to go about that. But then abdominal ultrasound as well, depending on the need for that case, but also availability. So
sure.
That's minimum, but just to get things rolling. Doesn't matter whether this dog showed up with one bout of diarrhea last night or whether this has been a 5-month-long process of PUPD, weight loss, not eating well.
Absolutely. Absolutely. Now, along those lines, I want to talk about that dog that showed up with just the one bout of diarrhea. And I have a story about my best friend in vet school. She had a puppy come in on emergency, and I think it was like some mild GI symptoms that were pretty acute. They just started, and the resident that she was working with said, "Well, what do you want to do?" And she said, probably just symptomatic care. He's just, it's just acute GI symptoms in a puppy. Who knows what he got into? Well, kind of along what you're saying, they offered everything. The owner went for it. They did an ultrasound. They found pythium in his stomach. And so, of course, the resident that was working with her, who we all love, was like, "Do you see why you should offer everything. And, of course, her reaction was, come on, like, how often are you going to find pythium in the stomach with these GI symptoms? So
That's the thing. Yeah.
along those lines, like symptomatic care versus jumping into the workup.
If you don't look, you don't know. You need to
Right.
actually investigate these things, right? And yeah, most cases probably will be your standard acute gastroenterocolitis or something like that, but you don't know what you'll end up missing. I'll give you a similar example. Let's say you have a dog coming in for a dental cleaning, they're dropping off that day, you're going to run some preliminary blood work, and you find out that maybe 1 or 2 liver values are high. Just mildly elevated. There's no symptoms of this at home, no previous history of liver issues. He's had dentals before and anesthesia before, but now you have a mild increase in liver values. Well, I get in the habit of, we're not going to pursue the procedure until I talk to the pet owner first to say mild elevations, the magnitude of elevation may not correlate to the severity of disease. If disease is even present, this could be just a transient liver situation. Maybe you bumped his stomach a month ago and the liver was like a contusion type scenario, or maybe there's a beginning of something. We need an abdominal ultrasound. Do you want to do it? And then let them decide. And if they say, no, I'd rather not, okay, realize that most anesthetics get processed through the liver. So if there's something wrong with the liver, this puts us at increased risk. If we can figure that out beforehand, it'll make the procedure more safe. And if we find out he's got liver issues, well, then we have bigger problems to worry about. And usually when you phrase in that context, they think, you know what, you're right. It's not worth for me to do this and risk my pet's safety. Let's work up the liver. And then you can get an answer from there. And I have found older dogs with liver masses and gallbladder issues, incidentally, because of this screening.
So I would love to dive into that a little bit more from a client communication perspective, because when I'm having those conversations with clients, I feel like I kind of walk this line of wanting to make sure that I'm offering them all the options, but not confusing them with all the differentials of saying, there's these mild liver values, it could be nothing, it could be something major, and everything in between. So what's kind of your advice, your recommendation of talking the client through that? And I think you just gave a really great example, but if you don't mind expanding on it a little bit more, and not making them feel like, well, is this not safe? Because I know for me, with these mild liver elevations, in a lot of cases, my clinical impression is we're probably going to be okay. Obviously, case dependent, but it's probably going to be okay. It's a mild liver elevation. I think we're going to make it through this procedure okay. And I want to communicate with the client appropriately, but not scare them with something that maybe I'm not super concerned about.
So you want to avoid, and this comes with experience, right, over time.
Yeah.
So you want to make sure that you're not guilting them into something. This is supposed to be a logical decision, not an emotional one necessarily. You also want to make sure that they feel as though you're not hiding something as a doctor. Well, this doctor knows, and she just won't tell me because she feels bad or something like that. And we don't really know. Elevated liver values could be anything. And then as far as giving the pet owner a list of differentials, I really avoid being specific with differentials because there's a ton of them and you don't have time for that. And honestly, most of it's going to be a waste because that dog probably has either one or none of those diseases. And so I do exactly what you said, which is I'll tell them it can range from a nothing, just bumped his tummy a few months ago, all the way to cancer and everything in between. I don't have an idea of where we fall in that spectrum, but that's why I'm recommending the test. And so that kind of tells them there's too much to talk about. It's not worth our discussion to worry you and all that. Really, all of it is a null and void until we have the ultrasound done, if we're willing to do it.
Sure.
But then also give them an out. Let's say they're scared about anesthesia. They can't really afford the abdominal ultrasound. They weren't really prepped for this today. What should they do instead? What's a good in between? Great. We know liver value half-lives is about 3 to 4 weeks. Let's recheck lab work in 3 to 4 weeks. If the values are coming down or they've normalized, maybe that'll make it better on both ends so we can avoid the ultrasound and proceed with the dental care, right? So you got to give them, don't make them feel guilty. Don't make them feel like you're hiding something and not telling them. Don't waste a lot of time and effort and honestly emotional distress by going over every single differential, and then offer them a backup plan in between. That's good. And from there, most pet owners, honestly, they'll go for it. They'll go for the testing. And when you explain all that.
Yeah, absolutely. And I think you touched on something really important as far as understanding your client and their motivation and where they're coming from. Certainly if you have a client who's already scared about anesthesia, that conversation might be a little bit different from someone who's like, listen, like I got him here for the dental. That's all we're going to get. We're either going to do it or we're not. Tell me what to do, doc. And making sure that you're understanding who you're talking to and having that conversation based on the client's needs and the pet's needs.
At the end of the day, your job as a doctor is not to tell them what to do. In most
Right.
cases, you're giving them options, the best to the worst, and everything in between. Once they decide, do not judge them for it. It's their pet. They can decide what they want to do. You arm them with the weaponry of pros and cons, costs of each thing, then let them decide. And you have to be okay with that as a doctor. You
Mm-hmm.
can't instill your own beliefs on that person. Now, not everything is that gray, right? I mean, if you have a gastrointestinal foreign body obstruction, and it's not amenable to scoping, let's say it's in the middle of the GI tract, it's either surgery or euthanasia. There's not much
Right.
else, right? So some cases it's very black and white. A lot of cases are not, and you can give them options. Then you need to be content as a doctor that whatever they chose is appropriate.
Sure, absolutely. To be the purveyor of information and help support them and help them make the best decision for them and their pet.
Correct.
I like it. I like it. And I'm glad that you brought up GI foreign body because that was kind of where my head was going next of, let's talk about, we mentioned dentals before, but thinking in an emergency setting, a GI foreign body, I guess nutritional considerations for a GI foreign body would be my question. And if we want to dive into a little bit more detail there, I do feel like a lot of times getting the diagnosis and communicating with owners about these cases, it can be a process and there can be a lot of nuance to it.
Most cases of gastrointestinal diseases, especially acute ones, well, chronic as well, obviously. We were talking more about post-op or post-disease recovery. And we usually, most conditions, we try to get these animals on enteral feeding as early as possible in the recovery phase. As long as we think that they can stomach food, literally hold it down and digest it appropriately, we want to get them started on it, whether it's done through feeding tube or whether it's done through manual, mastication, whether you're talking about starting slowly and then increasing in volume of the diet you're feeding, whether you're talking about prescription diets, something like ID, WD, these GI diets that are really good for them. You have to titrate that to whatever the case needs. Some pets can handle eating right away. Others, you want to do it more gradual. Just depends on the scenario. Most of the time, this is in the recovery period, and you're usually using a polypharmacy technique, right, where you have them on multiple different treatments at the same time, not just a diet intervention. You're doing multiple things: anti-nausea, antacid, fluids, etc.
Absolutely. And do you kind of have an impression as far as you mentioned feeding tubes versus mastication of the types of cases that we may want to be prepared for one or the other? I will be honest with you, I really don't like cutting GI foreign bodies. I try to let somebody else do that if they're willing to. So it's not something I have dealt with personally a whole lot recently. I felt like the ones I have cut, I do feel like they tend to be willing to eat fairly readily. But what are some of the cases where maybe we should be prepared for this one might not eat right away and we need to be prepared for that feeding tube? Or what's kind of our cutoff to say like, okay, we've gone too long with not being willing to eat. Let's go ahead and place a feeding tube.
So let's say, for example, you have a dog with a foreign body. It was stuck either like in the pyloric antrum or the proximal duodenum, like cranioflexure. It's right where the pancreatic ducts and the gallbladder, right, are. And so now you go in surgery, gastrotomy goes great, but you see the pancreas looks like it's raging pancreatitis. So that's a dog that I would expect afterwards to have esophagitis, gastritis, pancreatitis. And so feeding right off the bat may not be the best course of action to take, but eventually I'm going to want to because we want to start early enteral feeding. At the same time, I also suspect the stomach to become distended with fluid because the motility from gastritis, pancreatitis, esophagitis is going to be abnormal. So a nasogastric tube, for example, placed into the antrum of the stomach will allow you not only to feed when you're ready, but also for gastric decompression
Oh,
post-operatively.
okay.
So you can empty the stomach through a nasogastric tube and get that stomach deflated, for lack of a better word, decompressed. And then that'll help with motility of the stomach, help with nausea of the patient. And then once that fluid production comes down over the next day or so from aspirating the stomach, you can then start introducing a diet, and a diet that ideally where you can blenderize and fit through the nasogastric tube. You can start them at a maybe, usually do like 1/4 maintenance to begin with, and then every day sort of increase it, a third maintenance, etc. And until you can go to full maintenance. Then from there, if the dog looks like it's tolerating that, you can then think, okay, can we offer food by mouth and go from there? That's a really easy, common example of a scenario. And what's really good about that scenario is that you can either place the nasogastric tube while they're still under anesthesia for the surgery, once you've seen what you've seen in the abdominal exploratory, or post-op, that night or the next day or something. So it's not like a jejunostomy tube that gets placed in surgery under anesthesia, or else you can't place it. These nasogastric tubes can be placed intra-op or post-op.
Sure. Which means you can kind of see how they recover and see if you are having those complications you're expecting. And if you are, then always place it post-op, although I'm sure many of them appreciate it if we place it intra-op.
Yeah, in fact, I always prefer it. If I have a suspicion this dog may need a nasogastric tube because of gastric dilatation post-op from fluid production and poor motility, like gastric atony, for example, then I'm going to place it while they're under anesthesia in the operating room. Literally, my technician is passing it as I'm closing the abdomen. And then you can go right from there to radiology, check the placement of the NG tube, adjust it accordingly, then suture it in, and then you go into ICU for post-op recovery. In a facility like the ones I'm used to working in that has that kind of different departments and intensive care unit and things like that, that's how we would operate.
Sure, but even thinking in a general practice, it may not get placed right as you're closing the abdomen, but, placement immediately after closure and then move to radiology and then transfer and have on fluids. And ideally, we end up, at a 24-hour overnight facility. But even if not, a lot of those treatments, I think, can absolutely still be pursued, even in a private practice setting, just thinking from my own, experience and what we'd be able to do.
Definitely. Absolutely. And I actually have a fairly popular YouTube video on my channel that shows how to place a nasogastric tube, if anybody wants to look at that as well. But you will need practice. Make sure you have the different size tubes, and then where you want to place it is important. So just maybe as like a side note, I'm talking about trying to provide both gastric decompression and enteral feeding with a nasogastric tube. However, ideally you would like the nasogastric tube to not go past the distal esophageal sphincter, because that sphincter is going to be open, which causes reflux esophagitis.
Okay.
But I'm sacrificing that to be able to decompress the stomach. Let's say I have a dog that just won't eat, but there's no gastric distension, and I'm going to place a nasogastric tube. I'm probably going to have it end somewhere between the carina of the trachea and the diaphragm. And I'm not going to pass the distal esophageal sphincter because I'm not looking to decompress, I'm looking just to feed. And that's a more natural way of feeding because you're not passing through the distal esophageal sphincter. Does that make sense?
Yep, it sure does. That makes a lot of sense.
If you're going to start placing these in general practice, let's say, for example, you want to think about that. How far do you want to place that tube? It depends on what your goal is.
Sure. And I will say I'm very comfortable with esophagostomy tubes. I've placed several of those. Nasogastrics always are one of those that they just don't have as much of a comfort level as I do with esophagostomy tubes. So with that in mind, what is your YouTube channel where we can watch this video of placing it?
So if you search YouTube for my name, Dr. Shadi Ireifej, it should pop up. There aren't very many with my name out there that have YouTube channels, and you can watch there. I think if you organize the videos by most popular, because it's like least top 5 most popular on my channel. A trick that you can consider while they're under anesthesia, by the way, is if you have the technician pass the nasogastric tube, so just pick a nares, usually left, but it doesn't matter, and then as the tube is passing through the nasal cavity and it comes out the nasopharynx into the oral cavity, have the technician grab it, do kind of like tying of the tip of the tube through that small opening in a large orogastric tube that you'd use for like GDVs.
Yeah.
And then slowly pass that orogastric tube attached to the end of the nasogastric tube into the stomach. And if you're still doing your gastrotomy, you can then grab it, hold on to the nasogastric tube, so release it, and then they'll remove the orogastric, and now you have the NG tube. Yeah. So now you know where it is exactly. I still take post-op rads anyway, but you can do this under anesthesia and you know where it's going, as opposed to the frustration that we deal with when we're like, it's not passing, a dog keeps swallowing or sneezing or whatever. It's annoying. So that's a little trick you can consider as well.
Absolutely. I can see that being really handy.
Very useful.
Yeah, absolutely. So you brought up pancreatitis earlier when you said, you have this dog open for a GI foreign body and you see the pancreas is angry, and now we're dealing with that. Obviously, in most cases of pancreatitis, we don't have a dog open on the table, although it does happen sometimes. So let's just talk about pancreatitis a little bit in terms of diagnosis. It's not the easiest condition to diagnose, treatment, and nutritional considerations in those cases.
We rely really heavily on our diagnostics, especially blood work like lipase and amylase levels, because we can measure those in the hospital usually if your clinic has a in-house lab machine that runs those panels. Otherwise, we end up submitting those PLI tests out to a lab, and no test is perfect, and these things have their own accuracies and sensitivities and specificities, et cetera. Pancreatitis, like you said, is very elusive because it may not show up on any of these diagnostics, and there's varying degrees of pancreatitis from very mild to severe, acute, necrotizing, fulminating, and everything in between. So it's very difficult. So don't rule out pancreatitis just because the pancreatic values and the PLI and TLI and whatever are normal. But also don't necessarily go right to pancreatitis if you find these values to be elevated. For example, if you have kidney disease, you can have increase in amylase, for example, because it's eliminated through the kidneys. So it may not be a marker for pancreatitis. And so it depends. It depends. And then, of course, some pets that genetically have just increased amylase from lipase or whatever. So the point is, if you can, the ideal way of pancreatitis is visualizing it. And usually you're going to go non-invasive. And so typically abdominal ultrasound is the way to go. Pancreas is notoriously difficult to identify in ultrasound, especially if it's normal. But if you can't really see it, then how bad, if it is pancreatitis, how bad can it really be? If it's pancreatitis like fulminant or obvious or whatever, then hopefully your ultrasonographer can actually visualize it. Otherwise, you're not going to see it on upper endoscopy. And so the only other way of seeing it would be in surgery, which again, like you mentioned, you're not going to cut just to diagnose pancreatitis unless you suspect a pancreatic abscess or a tumor, or there's unknown GI obstruction and you find out, oh, we have a pancreatitis situation, or the extrahepatic cholestasis from pancreatitis. So there are times where you might end up in surgery, but ultrasound is probably the way to go to really confirm, especially if your experience tells you, boy, I really think this dog's got pancreatitis, and you're not finding any of your standard diagnostics, blood work, and radiographs, then ultrasound's the way to go.
Absolutely. Like we both said, I guess, you're not generally going to cut these cases. Although I have found in cases where, you do have the abdomen open and you see that red inflamed pancreas and you dump a bunch of fluids on it, I really do feel like they get better quickly.
Yeah, abdominal lavage is useful for many reasons. It removes enzymes, and part of the problem with pancreatitis is that the enzyme release causes not just auto destruction of the pancreas, but also the surrounding organs.
Yeah.
It also eliminates blood clots. It eliminates leukocytes, any debris from your surgery, contamination. Lavaging helps a lot. Downfall to lavaging is some studies report concern for spreading of cancer if you have cancer that you're dealing with there, and also it does increase anesthesia time as well for the patient. If you have a patient that's pretty critical under anesthesia, you want to speed up the process. So it's not always great, but lavaging for the most part, most of us will do it. It's worth it, and for those reasons.
See, I love that you just said that. One, you use the term abdominal lavaging. I said you just dump a bunch of fluids on the pancreas. So I like your term a lot better. And I was strictly going off my clinical impression of, when we've lavaged that abdomen and put a lot of fluids on this red, angry pancreas, they seem to do maybe a little better sometimes than the ones that don't get that because they're not in surgery. So I love that there's a little bit of science behind that to say, hey, my clinical impression was correct there. But good to know that there's some concerns with it too, because that I was not aware of as far as like concern with seeding cancer or anything like that.
Yeah, how realistic those concerns are, I don't know, but it's been reported. If it's in the literature, then it's fair game. And regarding the terminology, I'm a bit of picky with especially about interns and residents. I want them to use their big doctor words, and so I want them to use words like fracture instead of broken bone, for example, right?
Fair.
You ought to, I try to be as specific as possible when I speak about these terms, just to make sure it's clear. But it gets a bit annoying, as you can imagine, if I'm reminding them every single day. Come on, there's a word for that, guys. Hyperbilirubinemia.
Right. No, but
words,
we all need the refresher because
Yes.
sometimes, especially if you're doing a lot of owner communication and things like that, it can, you're like, oh, there is a word. What is the word? And so, it's a good reminder to make sure we're continuing to use our doctor words so that we don't forget them.
And these days with people with pet owners being so tech savvy with internet searches, they want those words. They don't want to be talked down necessarily. They don't want you to explain them, but they want to be able to Google thrombocytopenia when they're done with the appointment, do their own research. I'll put in air quotes. So it's good that way. And then also, if you're speaking at a level that they understand, but it's also at a doctor level, you gain more respect that way. They think you know what you're talking about, and you do know what you're talking about. But we as vets are really bad at selling that to people. And so we try to dumb it down almost too much to where it's like, are you even a doctor? Like they're just doubting you. Especially if you look young, you just graduated, it's going to be an issue.
I
was
used
going
to
to
have
mention one
that
more
problem
thing
a lot
about.
more than I do now.
Oh yeah, I know. Yeah, it's true. If I don't shave for a while, then people think I'm a lot older. That helps.
There you go.
In regards to pancreatitis as well, there is a radiographic sign of pancreatitis. I think it used to be called the reverse C sign, where with pancreatitis that's sufficient enough to displace the cranial flexure of the duodenum. You'll see the duodenum from the air, the gas from the stomach into duodenum. You'll see this duodenum being displaced laterally and cranially. It creates a reverse C sign. And so that might be a hint that you've got at least some kind of mass effect there in the area of the pancreas. Usually in that area, it's going to be the right pancreatic limb in the mesoduodenum, the abdomen. But anyway, that's just another a sign that you may want to look out for. By no means specific to pancreatitis. Obviously, any mass effect can cause it, but it may push you to say, well, we got to sonogram that area because that duodenum is displaced.
Yes, definitely a good reminder. I feel like I hope none of my radiology professors are listening to this podcast, that they did teach us about the reverse C sign, and it was not something that was top of mind. So I'm glad that you reminded us of that.
My pleasure.
What about dietary considerations in these cases?
Yes. So like we said, we want to start feeding these dogs as soon as you deem fit, whatever that means. That's going to be somewhat subjective depending on the doctor's experience in the case. And you're trying to, in the case of pancreatitis, you're trying to get them started on something that's a bland diet. Dietary intervention is serious. You need to pick the right one. Otherwise, you may end up inadvertently causing electrolyte imbalances or lipid values all over the place or whatever it's going to be. So make sure you know the right one you want to use. And then it depends on how you're going to feed it. If you're going to administer this diet through a tube, well, what size tube are you dealing with? How liquefied should this diet be? Is that diet consistency amenable to being blenderized and administered that way? Or if you're going to feed the dog, are you going to just let them have at it, or are you going to hand feed them small meatballs, then see how they can handle it? So a bland diet, typically a balanced diet. And then if you're planning on feeding this through a tube, you want to use the largest bore tube that you can that's realistic for that patient as well.
Yes, as someone who has spent time treating cleft palate puppies, large bore tube is key, or you will be there for a very long time.
Yes. Yeah. And then you're dealing with clogged tubes, and it's very annoying.
Yes. And I understand maybe we don't use Coca-Cola like we used to unclog the tubes.
I did. I still do. But yeah, that's probably not the best way to go. There's other products out there now, or something as simple as a stylet can hopefully unobstruct them. But
that makes sense.
Yeah, I went through the whole Coke thing as well.
Oh, yeah. I think, we've all done it at some point, right? And it works.
Yeah, it works. They'll do it at home because if they have a feeding tube at home, right? Unless they for like chronic diseases like cancer, for example, then the pet owner needs to be armed with the way to unobstruct the tube. And so
Sure. I do want to clarify something with you, and I don't mean to put you on the spot. My question is ID versus ID low fat in these cases?
Good point. Yeah. So the nuances matter for these cases. So so typically low fat. We tend to think that although pancreatitis can happen spontaneously, usually, most commonly rather, it's because the dogs got into something. They got into the trash, ate a bunch of fatty human food, high calorie human food that their body's not adjusted to, and then pancreas goes nuts. So the low fat is what you need. And don't worry about putting me on the spot. I'm more than happy to. I'm fine with it.
Perfect, because I have so many questions.
Very good point. Yeah.
Sure. Yeah. The fat restrictions with these. And I like that you mentioned the different feeding methods, whether it's tube or there's a difference between free feeding versus hand feeding and doing meatballs and how you're spacing that out. All of that really important in deciding how we're going to manage these cases.
Yeah. And we didn't really talk about total parental nutrition either. Is by no means my area of expertise. I've rarely used intravenous nutrition like that, but just to make sure that people who are listening, watching, knows that TPN and PPN do exist as formulations. Most places that I know of, they have to make those products there in-house. Right. I'm not sure I can comment too much more on it. Pros and cons of that treatment, just like everything else.
Sure. Yes, I think you and I are in a similar space with those of I have used it, I'm familiar with it, but that's about it.
Yep.
Well, let's switch to azotemia, which is a little bit less, kind of on the nose GI and more of an extra GI type of condition. I love talking about azotemia because I just think we can do a lot in these cases. There's a lot of differentials that we can come after and really treat. And then I think in most of these cases, not all of them, we can really get the pet owners some hope and get the pet good quality of life back, at least temporarily, hopefully in the long term.
Absolutely. One of the biggest downfalls, the two big downfalls that I see with azotemia being diagnosed, let's say in a practice, doesn't matter whether it's GP, ER, specialty, is we forget two things. Number one, there's three different broad categories of azotemia: pre-renal azotemia, renal azotemia, and post-renal azotemia. Pre-renal, the most common example is something like hypovolemia. Renal is most common, something like acute renal failure. Post-renal, something like urinary obstruction, right? Those are your classic examples, although there's many differentials for each one of those categories. And the way to differentiate between those three categories, amongst many other tests, but the number two error that I see is we don't check urine-specific gravity. And that's a telltale sign of which of those diseases you're talking about. Now, you can have more than one disease, which can confound things, right? But in general, if you want to know if there's renal function there, the urine-specific gravity is your key to at least tell you that preliminarily. And then from there, you can provide diagnostics to further delineate what are those causes of post-renal in this dog or cat. So we have to remember those two basic premises with azotemia. And don't forget, azotemia is not a diagnosis, right? It's a symptom, it's a clinical sign, it's an abnormality on blood work, but that's not the disease. You have to find out what's causing it.
And I think you make a really good point about the urine-specific gravity and why it's so important, especially in our older patients, to make sure that we're sending out urine if we're able to when we do those wellness panels that, we're just kind of monitoring every year, because watching that urine-specific gravity go down can be a really good monitoring tool if you do end up with a pet who's azotemic, to say, actually, this has been a long time coming and we're dealing with more of an acute on chronic versus, just an acute presentation, which has a different set of differentials.
Absolutely. And you mentioned sending blood work or urine out to the lab. Well, that also depends. So if you're a facility that has access to in-house blood work, or you have the option of sending it to a laboratory, we all like laboratory because their machines are constantly being calibrated, so their quality is right there. And they also have fancier stuff than most practices have in their clinic. However, if you're being presented with an animal that's sick, especially if it's like a Thursday or a Friday or like a long holiday weekend coming up, you want to know right then and there, ideally, what that animal is sick from, because you may not want to have that patient wait 24 hours plus for the lab work to come back in, right? They're sick right now. So try to use that as a differentiating factor as far as when you run in-house blood work and urine versus sending it out to the lab.
Yes, absolutely. A really important consideration. And it goes back to your first point of making the recommendations based on what's going on with your patient, not what you're worried about as far as cost and things like that, making sure those clients at least have the options and they understand the pros and cons of what you're recommending.
Yep, correct. Yeah.
What about nutritional considerations with azotemia?
So in patients that have renal disease, for example, KD is a good example of that type of diet where you have a well-balanced maintenance diet that's specifically used for patients that can't necessarily or should not have the high protein content. In the case of renal disease, for example, that proteinuria, that protein loss through the kidneys, is going to cause an osmotic diuresis, which then contributes to polyuria polydipsia, PUPD, and this clinical signs that are associated with this disease. So you're trying to lower the protein levels, but still provide them nutrition, because obviously you still need protein to build muscle and heal and all that good stuff. So you want the diet to fulfill all those categories, but not just protein itself. Sodium levels matter as well. Palatability matters as well. And a lot of times these kidney patients, they're nauseous, chronically nauseous. And so you want something that they'll actually are willing to eat. Assuming you're not going the feeding tube route, then you want something that they actually are willing to eat. And let's not forget too, a lot of these patients are on multiple medications. And it's hard to pill animals, especially sick ones that don't feel good. So ideally, if you can hide it in food, that would be a good way of administering the food.
What are kind of our considerations for when it's appropriate to place a feeding tube and the different types? You've spoken a lot to this already, but if you can't just kind of like summarize the different tubes and the considerations around them.
So your first consideration is going to be, what are you trying to treat? For example, if the goal here is to bypass, let's say, the esophagus, the stomach, or the pancreas because of disease being there or that's where your surgery was, then something like a jejunostomy tube, right? So a feeding tube placed in the small intestine will help you provide enteral nutrition and bypass the anatomic locations that you're trying to bypass. So what are you trying to treat? In the example we had earlier about gastric decompression, if you want to place a nasogastric tube, well, are you going to place it for feeding only, or are you placing for feeding plus gastric decompression? The reason why this matters is it comes to the second thing you're looking for is what size tube do I need? Because a nasogastric tube can handle a larger amount of food. You don't have to blenderize it as much when compared to like a jejunostomy tube, but it depends on the animal size, right? So a really small patient, an NG tube may be very, very tiny, like a 3 or 5 French, whereas a jejunostomy tube, maybe you can go like 8, 10 French plus, depending on the size of the intestinal tract. So which size feeding tube is going to give you the ability to feed maximally? And that's your second question. And then the third is going to be the what the owner wants. So if you're going to place a nasogastric tube, are you sending the dog home with that? Do you think it will have to go home with the NG tube? Can that owner handle the NG tube? If you're talking about a jejunostomy tube, then it once it's ready to be removed, which is about 10 to 14 days after placement, because you want to make sure that the jejunum and the abdominal wall where you place that tube has an adhesion formed. Is that pet owner going to come back in 2 weeks to have you remove the tube? So owner compliance, owner wishes also matter in these cases.
I think that's a really great summary and kind of gives us a good idea of the indications for the different types of tubes. And I love that you mentioned, the size of the tube, because yes, I've definitely had those experiences with having too small of a tube, and it really makes a difference. So while it might be easier to work with a smaller tube in the placement and everything like that, the animal may tolerate that a little bit better. What is really going to be the overall benefit in the long run?
Mm-hmm. And I know there are cooler tubes out there that I'm not speaking to because I just don't have the experience with it. There are tubes that you can, they've got like different tunnels in them. And so you can pass it nasally, but part of it enters the stomach. The other part of it is actually longer and goes into jejunum. And so you can kind of pick and choose, okay, I'm going to feed jejunum right now. And then once the stomach part is healed up, I'll switch over. There's also endoscopically placed tubes as well. Internal medicine doctors do this all the time with gastrostomy tubes. So there are other ways you can get large bore tubes in these dogs minimally invasively. So I want to make sure that, to be fair, that there are options out there beyond what I'm saying as a surgeon. I'm going to be biased in what I'm going to be placing, but there are many other types of feeding tubes that are least invasive and multi-purpose.
Very cool. I had no idea about the multi-lumen tubes. That's really interesting.
Lumen, that's the word, yeah.
There it is. Yeah. Sound like me earlier. I was like, what is it when they put a hole in the side of a cow? And he's like, cannulate. I'm like, that's the word. Oh. Well, Dr. Ireifej, this has been a great conversation, really educational. I appreciate all of your knowledge and your input, from your experience. Are there any take-home points that you want to leave us with?
I was going to actually mention one more thing. I was going to mention this in our earlier discussion regarding abdominal radiographs. So I want to encourage veterinarians to get in the habit of taking 3-view abdominal radiographs. We all know that with metastatic screening for the thoracic cavity, 3 views is standard. And I still see some vets that collect only 2 views for the thorax looking for cancer. And the appropriate thing is 3. That's because radiographs are 2-dimensional. So for abdominal cases, I do push for 3 views. I have had plenty of cases where the 3rd view caught the foreign body. And the other 2 views, it was not so obvious. So get in the habit of doing that. And the other thing I was going to mention as well is, let's say you have a case that also has urinary signs. Again, still going to be 3-view full abdomen, even though you want to make sure that the urinary bladder is in there. If you're dealing with a male, for example, you want to make sure you have the whole urethra in there. And so I do what's called a lateral oblique, where for the lateral shot, right or left doesn't matter. You can actually elevate the most dorsal leg, pelvic limb, right? And then the other pelvic limb is flat on the X-ray table. And so when you take your radiograph, it moves the pelvis. It shifts the pelvis out of the way more so that you don't have as much bony superimposition, and you can see the urinary bladder and urethra much more clear in case you were going to miss a stone, because stones that are radiopaque are going to look like bone. And so you want to be able to minimize that obstruction, the silhouetting. The point is 3-view abdominal radiographs, please, is standard. Obviously, if you only can do 2 for whatever reason, then you want a VD and then either right or left lateral. But 3-view is ideal if you can.
Yeah, and I have to echo that in my experience too, where it may be my shortcomings in reading radiographs, but certainly, especially when looking for a foreign body and really kind of looking at those gas patterns, I just feel like you said, in some cases you only get 2 and you work with what you got. But if I can get 3, it helps so much in just putting the pieces together of like, where is this gas? Is it in the small intestine? Is it in the large intestine? Is it different from the other gas patterns? And it just helps bring that whole clinical picture together.
And get the whole abdomen in there. So I know how annoying it is to radiograph a 180-pound dog. They have massive bellies, but you want to make sure that you're getting from like diaphragm all the way to pelvis, pelvic canal. So if it requires more than one take, fine. If you have to sedate the pet, if they're stable enough to be sedated, fine, sedate them to make it easier on them and on your staff. It's worth getting the full screening as opposed to just a third of an abdomen and say, that's good enough. I don't see anything obvious, but you could be missing stuff. A pneumoperitoneum shows up right where the diaphragmatic crura are on their way to the vertebral spine. That's where you see the gas on a lateral radiograph. And if you don't have that, if you're cutting off that part of the abdomen, you could miss a pneumoperitoneum. Not that they're that common, but the point is you want to have the full span.
Sure. And I do like that technique of doing the lateral oblique, because if you do have a 180-pound dog and, the 3 view turns into a 6 view by the time you get everything, and then you come back and you say, okay, but can you take one more of the pelvis so we can get the urethra? There's kind of a collective exhale in that moment where, you're kind of, persona non grata. So yes, If we can do that in the abdominal view, by all means.
Yeah, especially in those male dogs. Yeah.
Oh, yeah. Well, Dr. Ireifej, this has been great. Thank you so much for joining me. This has been a lot of fun.
I agree. Thank you so much for having me. If you ever want me back, I'm happy to. This is fun.
I want to say a huge thank you to everyone out there who joined us. I hope you learned a little bit about nutritional considerations in emergency cases, a topic that is maybe not always top of mind when you're dealing with the adrenaline of an emergency, but one that is nevertheless super important. A huge thank you to Hills for making this episode possible. Thank you to Dr. Ireifej for joining me and for the great talk. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals like you find this and other great content we try to put out there. For more episodes like this, click on the Education tab on the VetFolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassi DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day.